Welcome to our third Facebook Live presentation of the series, 7 Strategies for Thriving with Heart Failure. Today, we'll be answering questions focused on living your best life after a heart failure diagnosis. Thank you for joining us for this live broadcast from Mayo Clinic in Rochester, Minnesota. I'm your host and moderator, Dr. Sharon Hayes, cardiologist and founder of the Women's Heart Clinic here at Mayo and a member of Women's Heart's Scientific Advisory Council. Today, our panel includes preventive cardiologist and Mayo colleague, Dr. LaPrincess Brewer, heart failure nurse practitioner, and member of the American Association of Heart Failure Nurses, Ms. Tasha Freitag, and heart failure thriver and Women Heart champion, Brandy Taylor. Please start submitting your questions now, and we'll answer them throughout our discussion. As questions come in from our audience, I'd like to highlight that this is a 3-part series that has been aimed at shining a light not only on heart disease in women, but also the challenges that women face in the diagnosis, the treatment, and the living with heart failure. As with other types of heart disease, women have different risk factors for heart failure compared to men, with high blood pressure being a critical factor. Women's heart failure is different in other ways. They more often than men develop heart failure with normal or near normal heart pumping function. This is called heart failure with preserved ejection fraction, or HFpEF. This is important because this difference has meant that women have not been included in heart failure research, and there is not a single proven medical treatment or drug for HFpEF. And women living with heart failure are different in other ways. They are more often caregivers to others, which impacts their own self-care and well-being. Women more often experience depression and anxiety, which deeply impacts their quality of life. That's why in this session, we want to highlight not only the importance of clinical care that is so important to living with heart failure, but also those psychosocial factors that are important for women's ability not only to survive the diagnosis, but to thrive with heart failure and heart disease. Let's start our first question, and we can begin with Dr. Brewer. What are some of the potential emotional and social impacts of a heart failure diagnosis?
Yeah, so heart failure, we must recognize, can be a debilitating disease and can affect one's quality of life. One of the major risk factors for poorer outcomes in heart failure is depression. And it's estimated that approximately 1 in 5 patients living with heart failure have depression, and women are more likely to develop depression. And this is very important as this influences how they interact with the healthcare system. This can lead to worsening of symptoms, which then can lead to more hospitalizations. And this also affects their ability to survive and thrive with heart failure. And also we must realize that heart failure affects more than just a patient's heart. It also affects how they live. So it can affect their attitude and mood. It can affect their certainty about their life, also their confidence in their role at work and at home, and it can also lead to self-doubt in themselves and their physical limitations from heart failure. So it's definitely an important consideration.
So Tasha, as a heart failure nurse, this is your main practice. What else have you seen?
As Dr. Brewer said, I think, it's so scary. A diagnosis of heart failure, there's so much uncertainty when people are told they have, just even the terminology of heart failure is really scary. There's a ton of uncertainty about what's next in our future. Am I going to be able to do the things that I do at home, at work, for my family? Is my role going to change? Am I going to change? There's so much change in who we are and so much uncertainty that can be quite scary. And I think as in the field, we're starting to understand that it's more than just an emotional response. It's also a biologic response, that heart failure and depression kind of come together sometimes as a package deal, and that we need to do a better job of addressing both to help our patients do better, to help our patients thrive from both a emotional and a health perspective. And I'm sure Brandy can relate to some of the toll that takes a new diagnosis.
Yes, I absolutely agree. Everything that you had just described, I actually went through when I was diagnosed with heart failure. And being a mom and knowing that you have to take care of your children, I have 1 child, it does affect your life, definitely.
So here's a question on community support, which I think is perfect for you, Brandy. As a heart failure patient, how are you able to leverage your community and other non-medical resources to help you survive and thrive with heart failure?
Well, I'm a member of the Ipai Nation of San Isabel. It's a tribe that's located in Southern California. And as a community there, we always help each other out when any kind of event, bad event happens. And so I was able to really rely on my tribal community to come together and support me and my heart failure. And then eventually I had a heart transplant, and they were able to come together for that. But I know in other communities, I'm sure that women can reach out to church groups, clubs, and also a big part of my community is Women Heart. And I was actually brought to Women Heart by another Native woman, and I've been able to get a lot of support that way and meet a lot of women that have been through what I've been through.
That's great. Thank you so much. So I am, here's a question from Molly. Since my heart failure diagnosis, I feel like I'm on an emotional roller coaster. What should I do to feel more confident and more control? I'm going to start with you, Tasha, about this.
Sure.
Because you see people right at the beginning of the diagnosis,
and it's a
right?
really scary time. You know, a diagnosis of heart failure, again, just the title heart failure is alarming and scary, and you don't know what's next. And on top of that, we ask a lot of patients when they're first diagnosed. We ask patients to change their diet. We ask them to come to appointments day after day, frequent appointments. We ask them, we add medications almost every 2 weeks. We tinker with their medications. So just when patients start to feel like they get a handle on things, we change something. So it can feel like an absolute roller coaster.
It is a roller coaster.
So that said, I think, you know, you're also, when you leave the hospital or when you're first diagnosed, you also get a lot of resources thrown at you. And sometimes it's buried in a pile of paperwork, and it's buried in a bunch of people who introduce themselves to you, and it can be overwhelming. But if you can find a way to organize all of those resources and definitely take any and all resources that are given to you, in particular, enroll yourself or ask to be enrolled in a heart failure disease management program. We know that patients or people with heart failure who are engaged in a heart failure program do better both emotionally and with heart failure.
So for those who might not know what a heart failure, or has never been offered, and who are living with heart failure, can you tell us what a heart failure disease management program looks like?
Sure. Heart failure disease management programs come in different shapes and sizes. Most often they're championed by nurses. Nurses like myself who are a little bit nerdy when it comes to heart failure, and we kind of obsess about it. We get excited to hear what patients weigh in the morning and how much salt they ate yesterday. And we are, day in and day out, we should be there to help patients who are newly diagnosed all the way through the course of the illness, to help them manage adjustments in medications, adjustments, getting used to the illness itself, and help patients thrive. Another resource that patients should really consider is cardiac rehab. After a diagnosis of heart failure, particularly for patients who have a weakened heart or a reduced ejection fraction, they may be eligible to enroll in cardiac rehab, and we know that cardiac rehab helps patients both emotionally and physically with heart failure. It helps keep them out of the hospital and keeps them alive longer.
I think for heart failure, particularly because, one, you have to get out and go, and there's somebody there that can reassure you about things. I know that just being able to do that. So a next question that we have, women are not small men, okay? What should women with heart failure be aware of that may be different from men to support their surviving and thriving? I'm going to start with you, Dr. Brewer.
So, I would definitely say that, we really enjoy social support and being amongst each other. That helps us to thrive. So I must say that we must support each other so that we can become motivated to manage our heart failure. And that's how we're special. I think once we have that social support as women, we then can manage our heart failure better.
Yep.
Yeah, I would add to that. I think, when it comes to heart attacks, we know that men usually come to us with kind of the classic chest pain symptoms, and we know that women usually present with slightly different symptoms. We don't have the equivalent in heart failure. At least we don't know of that yet. But I would argue that my heart failure patients that are women tend to come to me and they don't have any complaints. They come to me and I ask my kind of typical standard heart failure questions. Do you feel short of breath? Do you feel fatigued? And they're like, no. And I kind of go through the script, but I can look at them and see that something's not right. So I would say that as a woman, we tend to be accommodators. Women tend to adjust to get the job done. And that's not a dismissal of men as a gender per se, but as an example, I had a patient who came in and I saw her for weeks and I couldn't put my finger on it, but something wasn't right. And I kept asking her the standard questions and she kept saying, nope, not short of breath, not fatigued, nope. So finally I asked the right question one day and said, tell me about getting groceries. Are you able to carry?
Practical. Yeah, practical.
Yeah, and she said, I can bring the groceries in. So I thought, oh, that didn't do it. But then she said, I just have to make more trips. Mm-hmm. And I said, how many more trips? And she said, well, now I have to carry a can in at a time. Mm-hmm. And originally she could carry 2 bags in at a time, but now she carries 1 thing in at a time because otherwise she's completely fatigued and can't do it. So I think as women, we are not little men, and we might have different symptoms, but we also might adjust differently. So be persistent.
Well, I think just getting a question from our Facebook Live audience from Maggie, managing fatigue is one of the hardest things to overcome. And I think that is almost a universal symptom at some point for people with, do you have some tips on how you manage fatigue? What do you do that helps you thrive so you can do the things you want to do?
Well, I definitely rest when I need to. When your body tells you that you're tired, I actually take that and take time for myself and to lay down. But what you just said about, the fatigue, just basic functions of just going to the grocery store, taking a shower, of being that tired, but you do absolutely have to take time for yourself and rest.
So here's another question. So as a caregiver of a woman with heart failure, so spouse, children, friends, how can I be most supportive of her in ongoing care and well-being? I'm going to start with you again, Brandy, because you probably have the most perspective of what was helpful and maybe what was not so helpful.
Well, definitely I called upon my family to help, and I'm blessed that way that I have family around me all the time. But there's also what you said, the whole psychological thing too, is that when you're a mom, you're supposed to be strong and you're supposed to put, your children first, and that's what we've always been taught. But there are times when, you are tired and you start to doubt yourself a little bit, like what you guys have said. And I think that just being able to ask for help is a big deal. Just ask for help. It's okay.
That's a hard one, though, for women, isn't it?
Yes, it is.
It is, right? If you were the one who was in charge for all of that. What other things do you coach people about, the caregivers? Because you're both going to be seeing people who are seeing your patients.
So, it's natural when you're first diagnosed with heart failure to withdraw. But I really encourage those recently diagnosed with heart failure not to isolate themselves and to truly try to re-engage and socialize with others, whether this be with social groups such as with Women Heart or participating in cardiac rehab, which can serve as a social support group. And even if you need more specialized care with a psychologist or a psychiatrist, that is totally fine. But studies have shown that those who re-engage and socialize more have improved outcomes with heart failure, and they also are able to manage their heart failure better. So I would say definitely socialize and engage.
Yes. Thanks.
And I would add on kind of 2 elements. So first being on the medical front, I would say if you're a caregiver, helping your loved one get to their medical appointments or helping them schedule medical appointments, maybe signing up as a proxy into their electronic health record so that you can help them manage their appointments, their results, their correspondence. Of course, giving them the space to be autonomous and make their own decisions. Picking up their prescriptions for them or help setting up their pill box. doing grocery shopping, or at least supporting them in their dietary changes, and maybe diving in on those dietary changes too.
Which are probably healthy for everybody in the
Right.
family and all the caregivers,
Right.
right? So, I think some of the things that you mentioned, Tasha, are really about decreasing the work of being a patient. Heart failure is one of those conditions. There's many conditions, particularly chronic conditions, where there is work associated being with the patient. And so many of the things that you all suggested were really sound little, but one less trip to the pharmacy, right, can mean you have time to hold your baby, right?
Yes.
It is one of those things. So I think thinking about those little things and not taking for granted. But what I sometimes hear from particularly women, and they can't do everything that they wanted to do before, but they want to be, there may be some things they love to cook, they want time with their children, and people start taking those things away from them too. Like, just sit and we'll watch out. So I think there is a balance, right?
There
That
is.
they're still people, they're grown-ups, they're adults,
Yep.
right? Have you had anybody who tried to tell you just we'll take care of everything, or don't do something, or overcare?
Yes, well, definitely. With my tribe, actually, my son is one of our traditional singers and dancers, and I dance as well. And my family's like, maybe you should stop dancing for a while, but that's what kept me grounded. My culture kept me strong, and I'm like, no, I still want to dance. And our dancing isn't very strenuous, but it is exercise. And so after many discussions, they said, go ahead and do it, because it kept me in a good place.
Joy, right.
It kept me in a very good place. So.
And I'm sure there are many things, like unloading the dishwasher, or
They
that
could
you'd
do
be
that.
happy to surrender.
Laundry. Do
Yeah,
the laundry.
exactly.
Oh my goodness, yes. Do the
Well,
laundry.
I think that any illness almost any illness, there are losses. Even if the loss is my sense of being healthy, right? And so whatever you can retain that is that brings you joy, or like dancing, or caring for your children, or going to work. I mean, for some people they say, well, it's time, but I think helping find the balance and asking the patient, right? Right? So I have another question. Oh, well, this is a good one. That's not it, but it's a common one. So I'm going to start with you, Dr. Brewer, but if someone, well, I'm going to start with the patient again, because you are the expert here. So this may have happened to you. So if somebody is struggling from recommendations from a cardiologist regarding their heart failure treatment, what should they do to take more control?
Oh, definitely women need to advocate for themselves. Definitely. I know I was misdiagnosed with heart failure and went to 2 different hospitals, and I knew something was wrong, and the doctor dismissed me. But definitely you need to advocate for yourself. If you know your body, something's wrong, you're not feeling good, go to another doctor then.
So, and I think this is a corollary as well, is sometimes, doctors are far away.
Yes.
You have to travel, I know, to see your healthcare providers. And you go and they make one of the 40 recommendations that Tasha does. And maybe one of them doesn't work out, or you think maybe it doesn't work out. It's really common to just say, I'm going to stop that. I'll wait till my next appointment in 3 months. Have you had experience with that, where something didn't work out, and how did you deal with it then, and how might you deal with it now?
Well, at that time, because of just being scared on not being able to breathe and being very weak, and I was pregnant at the time too, that I did reach out more. I know just, being a pregnant woman, there's a lot of expectations on us, and definitely to be strong, and women do this all the time, but when you're a young woman that's pregnant and you don't feel right, you start to question yourself. But definitely, because I was feeling so bad, that's why I went to a second hospital.
Yeah. So, Dr. Brewer, you've done a lot of work with communities that focus on culturally tailored care. Can you speak a little more about why it might be important to have care that actually is individualized to both communities or individuals?
Yeah, so I must say, if you're having any, challenges with your care from a heart failure standpoint, definitely communicate that with your provider. It is our responsibility as healthcare providers to meet you where you are, so that we can best tailor our care to meet your unique living circumstances, whatever they are. And culturally tailored care is extremely important and has been shown to improve outcomes and health disparities. So if we do not meet patients where we are, we're going in a circle. And also, culturally tailored care allows us to tailor your heart failure medications, issue referrals to resources that would benefit you. So culturally tailored care is extremely important. And some of the work that we do in the community regarding culturally tailoring of interventions is primarily with the African American faith community. And we've not only improved health outcomes per se from a risk factor standpoint, but we've also improved their social support. They feel like they're able and more confident to integrate healthy behavioral change, and they also feel as if they have more support from their family and friends. So it really shows the power of tapping into social networks while also integrating culturally tailored care.
Can you give me an example of some culturally tailored care for the African American faith communities? What might somebody who's not a part of that community be surprised or just learn that might not be the regular healthcare provider or another community?
Yeah, I would definitely say that the value of social networking. They are very close knit. And it's really important that you value their environment, and also that it's not just the individual sitting in front of you, but they're also taking care of their families, their kids, their cousins. So they take whatever you're telling them in the healthcare setting and distributing that out to their communities. So it's really important that we develop, that personalized conversation with folks to really know what their social determinants of health are.
Yeah. Tasha, do you have anything to add?
I think, tailoring medications to the individual is a key role of the heart failure program. As we talked about earlier, those early on after diagnosis, we have frequent appointments and we're adjusting medications almost every visit. And part of that is that tailoring of the regimen, because we call it tinkering, and it's not like we're tinkering like you're a guinea pig, but it's getting you to the right dose to get you the maximum benefit without any side effects or as minimal side effects as possible. So I think, counting on your team and relaying what you're feeling and being persistent is key.
So here's a comment in response to that last question from one of our viewers that says, please don't stop your medication. It's really important that you talk with your healthcare team. So we've got people weighing in online who are really affirming this.
I think with the culturally based program that she just talked about, it's very similar with tribal nations as well too. And I think maybe with the Latino families and maybe Asian families, that there's also 3 generations that live in the home most of the time. So you are taking care of not only your mother, maybe sometimes your grandma is still with you too. So there's a lot of emphasis on that.
And then another thing I'd like to add, when you're speaking of depression and emotional support in these populations, they may not feel comfortable bringing up that they're having any depressive symptoms. So that's a way that you have to tailor your care. And this is in special populations, not only women, but also racial, ethnic minority groups.
Yeah, you're right, because we haven't really addressed this, but particularly depression and anxiety and other behavioral health or mental health illnesses, there's a lot of stigma involved.
Yes.
And the stigma involved in every culture and community, but it is more prominent in some than others, where the belief system is you should just be stronger.
Yes.
Right? Does that resonate with you?
Oh, yes, definitely. Yeah. And I'm actually an elected tribal leader too. So, and I've definitely dealt with depression with my diagnosis and with my heart transplant. But I've been trying to reach out to my community saying it's okay to ask for help. And that's what I keep restating to them, that, I've been through this and I'm asking for help. You can ask for help too.
Yeah. How do you counsel patients to help them, or even help caregivers accept that they need help? Because I think sometimes that's the case. Is I have a patient who's asking for help in this regard, and their family member may be saying, "Oh, you'll be fine. You just need to get more sleep." And I think that helping the whole community understand how thriving means having your whole, not just your heart, right?
I think
Just your heart.
I grew up in a very rural farming area where you just buck up and deal with it, you know? And so for me, I think what resonates for me and what I often end up communicating to patients is what we said earlier, is that we're starting to recognize that there is some chemistry behind this, that this isn't a weakness of character or that somebody just can't get their wits about them. This is actually, there's something going on. There's some relationship between heart failure and depression or mood, whatever you want to call it. And even if there wasn't chemistry, you're not at fault here. I mean, this is a big deal. This is, and it doesn't hurt to help this.
So one thing that I sometimes talk to patients about is I emphasize how I firmly believe, and I mean it's my own belief about the importance of the mind-heart connection, and those who are not quite ready to accept that maybe anxiety or depression is feeding into their symptoms, to talk about how I think, yes, you have heart disease, but your heart disease won't get better until we address this as well. And sometimes that conversation where it's all part of one can be helpful. I think particularly for women, and I know this happened with you, in your diagnosis or misdiagnosis, is they may have been told that their heart failure symptoms were anxiety, right? And so they've had an interaction with a healthcare provider that has dismissed them because, and so for me, it's a delicate thing for the three of us to talk to a patient and suggest that some of their symptoms might be due to anxiety or depression, because they can hear, you think this is all in my head.
Yes.
And so it is walking a tightrope. You want to tell about your experience? It hits me in the head that when you had that doctor tell you, well, you're 8 months pregnant and this is just how you're supposed to feel.
Yeah, and deal with it. Well, the Thursday before this all happened, I went into our Indian health clinic, and they thought maybe it was asthma and wanted to prescribe me an inhaler and sleeping pills. And I'm like, no, it's worse than that. And then the Friday when I went to the hospital, actually an emergency, and our hospitals are an hour to 2 hours away. The closest one is an hour, so my mom took me there. And the doctor said, oh, well, you know, you're 8 months pregnant. My wife is 8 months pregnant too. She's tired. Just deal with it. And they literally had to wheelchair me out. And I'm like, this cannot be normal.
No.
Yeah.
No. And so for somebody who has had that experience, having a healthcare provider introduce something that may not be directly due to your heart failure is probably a little bit harder message for some women to accept, right? Because you've been betrayed before.
Yes.
So the next question that we have is, what they like what we're talking about. What are some resources I can look into that cover some of the things that you've mentioned today? I'll start with you, Tasha.
There's a couple of great resources. American Association of Heart Failure Nurses has a website that has some great, just one-page educational documents. And then togetherinheartfailure.com, I would recommend, and that's a great resource if you want to connect with other heart failure patients or other heart failure caregivers. You can get on there, connect. Also, just this organization, just being right here.
Yeah. You want to give a plug for some of the things that you have found helpful as a patient?
Definitely Women Heart, and also there's also links for Indian Health Service that has heart failure, because I know even though our population is very small, it's only 1% of the United States population, we do have the highest risk of heart disease.
Yeah. And then there's a number of Mayo Clinic
Yes.
resources, mayoclinic.com. People can get those links as they'd like to. From Maggie, what should women be tracking and reporting on during their appointment? What do you want us to be telling you during our appointment? Symptoms, lifestyle? Heart failure nurse who does this every day. I'm going to ask you, Tasha, to start.
Well, we tend to obsess over daily weights. Unfortunately, the data on what the daily weight tells us is pretty poor, but it's really the only objective number that we can get over the phone. It's hard. There's a lot of causes for shortness of breath and swelling, so the weight gives us one number that we can sort of latch onto. But with that, we're interested in hearing if you're more or less short of breath than you were yesterday, if when you're sleeping, if you had to sleep, if you were able to lie flat, or if you had to sit up more than you did the night before, or even more if you had to sit up and catch your breath at the side of the bed. Certainly any swelling, any bloating. Women often also complain less of swelling in their ankles, but more of like, oh, my pants are just too tight around the waist and I can't explain it. And then the fatigue, like we were commenting earlier, you might not feel short of breath because you're not racing up the steps, but you might have just slowed down to not get to that point, and you're just a little more run down and can't put your finger on what's causing it. So keeping track of those, I encourage people to journal all of those symptoms, and then questions. Because you always come to appointments and be like, oh, what was that question I was going to ask?
Write it down.
Right. Exactly.
Do you bring a list? Do you have a book? How do you manage the complexity of...
I've had to do that, write questions down too. And I have a ton of medications, so constantly I have to bring in my list, and sometimes I'll even bring in my bottles.
That's great.
Yeah.
Yeah. You brought them today.
Yeah, I
didn't you?
did actually. I don't know. Yeah, this is my medication with being on a heart transplant, but I do have an apple and an orange in there.
Okay, so you've got a healthy snack along with
Yeah.
the many other things that you will be taking today.
Yeah, a lot of people have misconception of heart transplant that it's actually a cure for heart failure, when actually, we have to continue to go to doctors. We have to have biopsies constantly. We have to have angiograms. It's still constant upkeep with a lot of medication that I'll have to take the rest of my life. Immune suppression drugs and anti-rejection drugs.
So it's the work of being a patient
Yes.
is still very much present
Yes,
for you.
definitely.
Right?
Yes.
Right. But you're thriving.
Yes, definitely.
So here's a question from Thea. How do you communicate that you would like a second opinion, and would you get that opinion within the same practice? So I would start with it depends on the second part of that, but why don't how do you counsel patients, or would you counsel a friend to get maybe a second opinion about their heart failure symptoms?
I would first of all ask, how is the communication with you and your provider? And as Brandy so eloquently showed us, it's all about having self-empowerment and showing what you want. So it may be that there just may be a lack of communication that can be overcome with that provider. But if you try that and that doesn't work, then I would say, well, maybe we should seek out other resources if you aren't getting your answers from that provider.
I would agree. I'm actually of the belief that if you have a provider who is offended if you're interested in a second opinion, then that is evidence to me that I need a second opinion. I'm a little
maybe a different provider.
Yeah. This is your life you're talking about, and heart failure is a serious chronic illness that is often terminal.
Yes.
So I think it warrants a second opinion.
Yeah. So, and I think that here's perspective, because this is some of the data that we know for women with heart disease. So women with heart disease, first of all, they are less likely to even be cared for by a cardiologist. And even if they have a cardiologist, they may be less likely than men to be referred for advanced heart failure treatments like left ventricular assist devices or ICDs and other. So it may be that a woman needs to ask, and it's not to change to a different doctor. It may be that it is, I need a second opinion to make sure I do or don't need that higher level of care. And that, again, I'm a huge, for cancer, for heart disease, for those things, second opinions, they either affirm your doctor's doing a great job, or they have a nuance and give you more options. So, but the second part of that question was how in the same practice, and that can be if those two doctors, two cardiologists, have different specialty expertise, as is the practice that, the practices that we have, there may actually be a role for not necessarily changing doctors. I might send them to another colleague to give some insight. So in that case, but if you're just asking to change from one doctor to another in a small practice, that sometimes can ruffle feathers because all people have egos. So I think that part, it sort of depends. Any other perspectives on that?
I'll tell you, as a nurse, the nurses often
you
feel
all hear
this.
about it.
As a nurse or a nurse practitioner, we often field this question of, I'm not comfortable with so-and-so anymore, or I've heard great things about so-and-so, what do you think about switching? And generally in our practice, it's we just make it happen, and we try to make it happen as gracefully as possible, because at the end of the day, we're all here to help patients.
Right.
I had kind of an experience like that too. The cardiac center in San Diego, I first had a doctor that dealt with, he said he was an electrician and dealt with the heart failure with a pacemaker and all that, but that wasn't working, and he said, I'm going to go ahead and refer you over to the plumber, which is the doctor that dealt with heart failure, which, honestly, I mean, just even the electrician and plumber terminology helped me, and I'm thinking, he knew that he couldn't go forward more with what his expertise was in, so he gave it to his colleague.
Yeah. I think so. I can't skip this opportunity to talk about the role of advanced heart failure. So as we're talking about, there's kind of subspecialties. So you would think cardiology is a specialty enough of itself, but cardiologists can actually further specialize and spend many, many more years and further specialize in other disciplines. And that speaks to what you're talking about with electricians and plumbers. And we kind of sometimes use those sort of contractor terminology to describe what we specialize in. Heart failure, there's actually a specialty in advanced heart failure, and that's for those of us that practice often in large academic medical centers where we do heart failure transplants and mechanical circulatory support, or LVADs. And what we would recommend, you need a referral to an advanced heart failure center when you're having repeated heart failure hospitalizations, when you're clearly deteriorating despite being on the right medications, when you're just not thriving despite doing your best. That's when it's time to consider at least an evaluation by a heart failure provider, and certainly if you're having those heart failure hospitalizations.
Yeah. All right, we've got another question. I suspect I might have side effects from my medications, and most people with heart failure are on lots of medications. I'm tempted to stop them to see if I feel better. Maybe just try vitamins and supplements. Is that safe? Okay, Tasha, you can start with that.
You probably could tell by the look on my face.
No poker face.
Yeah, I don't have a very good poker face. No. It wouldn't be safe. And our first recommendation right off the bat would be this needs to be communicated with your team. Any changes to your medication should be communicated with your team, whether it's starting or stopping a medication. Work together with your team and communicate all of that, whether you're interested in a new supplement, a new vitamin, and frankly, even if it's an illegal substance, it should be reviewed with your medical team. We're not here to judge you, we're here to help you. That being said, there isn't evidence to support, it's not that we're opposed to those over-the-counter vitamins, supplements, etc. It's just that we don't have the evidence to support their use. In contrast, we do have evidence to support, particularly in heart failure with reduced ejection fraction or weak hearts. We do have evidence to support the use of the medications that the prescription medications that we use.
Dr. Virgin.
Yeah, and I totally agree with everything you said, but I also wanted to emphasize that, if you're having side effects from medications, it's really important, as you said, to communicate this with your provider, as we can also adjust those medications. We can also find alternatives to the medications. And also, this could be a signal for something that's totally unrelated to the medications. Mm-hmm. So it's really important to communicate that.
And I think sometimes patients think, because they've told me, they've said, well, you gave me that medication, it didn't work, or I had a side effect, so I just stopped it. And I'm bringing them back in 3 months to check on how that medication has worked for them, and they're not taking it. So that's a waste of time for both of us. And if they'd only picked up the phone or gone through the portal and said, it's not working for me, usually we have like 3 or 4 others that are alternatives that would have been easy. So I think communicating that communication is so important, right?
Yeah, and definitely a lot of patients, I know I've even done this too, suffered through some symptoms waiting for my next appointment. And all you need to do is call. I've had this rash for 3 weeks, and but I knew I had this appointment, so I thought I'd have no. Yes. I would have liked to hear about it. Yes.
So here's a question from Dawn. It's about a specific device, but it's a bigger question. So it's, does a group have feelings about a cardiac MEMS device? My cardiologist is recommending it to monitoring and keeping me out of the hospital, and it's in a clinical trial. And rather than answering about this specific device, I'd like for all of us to talk about clinical trials, women, heart failure. I'm not big on feeling like a guinea pig for a trial. Tasha, do you want to talk about, I'd like both of the physicians, but also
Sure.
you.
So I think, historically women have been underrepresented in clinical research, which is in the end a detriment to all of us. It's put us in this position now where we're kind of hypothesizing about the symptoms of how do women present with heart failure and how are we different and how do we respond to treatment. And I think if more women participated in research, we would have more answers and we would be in a better position today. So I say that first off.
Okay.
Second off, the implantable remote monitoring is far more successful than non-implantable remote monitoring in heart failure. We talked earlier about weight monitoring for heart failure, and we know that statistically it really doesn't do any good alone.
Okay.
When it's paired with a comprehensive disease management program and day-to-day management by a nurse, it does okay. But implantable cardiac monitoring, such as the device she's mentioned here, per the Champion trial and a couple of trials since then have shown that it does help keep people out of the hospital. And there is currently a trial going on now to expand the coverage or the indication for implant. So I think there's promising evidence, and we'll see where it goes from here.
Yeah. So in general, Dr. Brewer, what are you, I know you're a big advocate of participating in research, but why is it particularly important for women and people of color and minority communities?
Yeah, so it's extremely important for women and racial ethnic minorities to enroll in clinical trials so that we can know if these interventions and medications actually work in us and for us. If we're not at the table, then we're kind of just blindly giving out these medications and interventions without knowing if they truly work in these special populations. So I'm a strong advocate, as you know, for increasing representation of these groups in clinical trials, and it's a way for us to be at the table.
I actually had the CardioMEMS device, and I was one of the first patients in California to try it, and that was 13 years ago. And from what I've understood, though, is that it's gone to St. Jude's Hospital or to their research department now, and they're possibly using it on children. But it definitely helped me because I live so far away from a hospital that, and also we don't have really good internet service where I'm from. So, that's also like other rural communities, but you're actually able to plug it into a phone line. And those pressure readings I would do every night. My son actually would press a little button for me, and he was very interactive with it. And that saved me a lot of hospital visits. It also saved me when the doctor called and said, "You need to get in now."
Yeah, so it was a proactive response.
Very, yeah, I recommend it.
Yeah, so I think beyond that, that we know from people who participate in clinical trials or just research, there are other things that come along with it, often more visits to the doctor that are covered by the research, testing, and other things. So on average, people who have the same disease processes who participate in research actually have better outcomes. And it isn't because, so I think reframing the guinea pig, because nobody wants to be a guinea pig, is how I can be a contributor, because clearly you were, by doing this, both to yourself and to others.
And thanks for sharing that as well, because it truly shows how interventions can be tailored to meet your needs. As you mentioned, kind of your location and just kind of the convenience of that helped you. So that helps us to develop better interventions for our patients. So thank you.
So we've got a question that isn't directly heart failure related, but it is from a SCAD heart attack survivor. And for those in the audience who don't know, spontaneous coronary artery dissection. So it's a type of heart attack where the artery splits, can lead, and if you have a big heart attack, to heart failure. How do I convince conventional cardiologists that I'm not considered a patient with coronary artery disease, never had heart issues, blood pressure normal, and normal cholesterol? So I think that's, there's actually a corollary with heart failure, because you can feel completely normal and have reduced heart pumping function. And so there's the different views. I think just maybe some definitions, because one of the things I do in my practice is take care of patients and research spontaneous coronary artery dissection. It isn't so much coronary artery disease, but it is heart disease. Most people who've had a SCAD have had heart damage. And so it is heart disease writ large, but we don't treat it the same way as we treat a heart attack caused by plaque rupture. It's kind of the analogy in heart failure. We don't treat heart failure with reduced heart pumping function the exact same way as we do with preserved heart pumping function. The more I think that we can customize the care for all of these conditions, and particularly among women, the better. And I'm not asking you to talk about SCAD, but maybe the importance of customizing treatment to the actual cause. Your practice is mainly reduced heart pumping function, or do you care for a lot of HFpEF?
Yeah, actually, so HFpEF or the preserved ejection fraction is, in the general population is 50 to 60% of heart failure nowadays, and probably was all along. We just didn't recognize it
because it was in women.
Yeah, exactly. So we care for like 50% of my patients are more than likely HFpEFers. It's probably a little less because I'm in an advanced heart failure center, so we tend to do reduced ejection fraction more because we're working towards transplant and mechanical circulatory support. That being said, the challenge with HFpEF is that, as you mentioned in the introduction, we don't have any evidence-based or guideline-based medications to give for HFpEF. So we have to target the risk factors for HFpEF. And one of those risk factors is gender or sex, and we can't change that. So we can change hypertension, we can control the heart rhythm, we can work on body weight or maintaining a healthy body weight, we can work on sleep apnea. So we try to target all of those things and manage the fluid.
Right.
In contrast with heart failure with reduced ejection fraction, we have a robust guidelines that have been in place for many years, and we adjust them every couple of years. And just in the past couple of years, we've had the addition of a couple of new medications that we're excited about, and we're slowly catching on to implementing those new medications.
Yeah. So I just want to say there's a couple of comments saying how great, from your champion colleagues, saying how great you're doing.
Oh, that's nice.
They're coming up on the feed, so I think that's great. From Joanne, when will I know that I'm healthy enough to resume romance and intimacy with my spouse? Okay, I'm going to start with you, Tasha.
So that's an interesting question. Honestly, there aren't a lot of limitations about resuming romance with heart failure, as long as you're not having active chest pain and you've been if you don't have coronary artery disease, if you have been cleared by your cardiologist, if you do have coronary artery disease, there aren't limitations from a heart failure perspective. We do have recommendations that are a little more sensitive in that we recommend, to be frank, positions that are comfortable.
And more energy saving, perhaps.
Yeah.
Right?
So if you are short of breath and can't maintain that position, then you need to adjust.
Right. Right. Other thoughts?
So, I just wanted to applaud that person for even bringing that question up, because sometimes that is taboo to talk about our sexual health. So it's really important, because if that's not addressed, then that can then lead to depression and other mental health challenges. So thank you for bringing that up.
Well, I think we're talking about thriving, right? We want to get back to whatever is important to us, and for most people, having intimacy with somebody is important, right? So if someone is doing, another question, if somebody is doing everything their doctor tells them, but isn't feeling they're getting any better, what should they do? I'm going to start with you, Brandy, as a patient. So this has probably happened to you before. What did you do that you would recommend somebody else to do, and maybe you did something you would not recommend?
Well, definitely the communication with your doctors is very, very important, and to bring up if there's any additional symptoms that you've all of a sudden noticed, or any more of the any kind of medication issues, that type of stuff, but definitely you need to communicate with your doctor.
Yeah.
Yeah.
Tasha, what about you?
I think we've touched on some of it. Be persistent, and like Brandy just said, bring up the symptoms that they're not asking.
Yes.
Tell us how your life is changing, because
Yes.
maybe we're not asking the right questions. And then, as mentioned earlier, if you're continuing to fail and you're not getting a response, consider a second opinion.
So, Tasha, can you talk a little bit about, because you work right in this space, some of the advanced heart failure treatments that somebody who maybe they are on a really good medical program, and they're following, and they have a good relationship with their doc, but that next level of care, we've talked about the implantable devices. People may not know exactly what left and right ventricular assist devices. I'd love for you to just share a little bit more so people know what other options there might be.
Sure. So for patients who have reduced heart function, or what was formerly known as systolic heart failure, or a weak heart function where their ejection fraction is reduced, as the heart failure gets worse, they may become eligible for a heart transplant or a mechanical circulatory support, which is most commonly a left ventricular assist device, which is, in layman's terms, we're in the Midwest here, so we have a lot of farmers. So I often describe it, and I think the companies might die if they hear this, but I often describe it as a sump pump for your heart. So it's a mechanical pump that we insert in the left ventricle of the heart, and it helps pump the blood from the left ventricle forward through the aorta. So it kind of takes over some of the work of the left ventricle. So like a sump pump draining the overflow from your basement, this kind of helps drain the overflow from your heart and alleviate some work from your heart. It keeps things moving forward, and it can be implanted as bridge to transplant, so to help keep you alive and functioning well until you're able to receive a heart transplant, or as destination therapy for patients who are not transplant candidates. So in those cases, the pump is implanted and it stays with you until you pass.
So I think that there are, and then there's pacemakers that can help it sort of make the heart contract more efficiently.
Yep. So biventricular pacing can help in heart failure, especially again with the reduced ejection fraction. The heart can kind of go from what typically looks like a football shape at the bottom to kind of a flat basketball that needs to be filled with air. And when it has that boggy shape, the two sides don't work together. So a normal heart would kind of pump together. It's synchronized. But when it gets all boggy like this, it's not working together. So in those cases, and there's certain criteria that has to be met, but we can place an electrical lead here and an electrical lead here, and we can tell the heart to beat and synchronize the left and right side of the heart, and that's called biventricular pacing.
Or resynchronization therapy.
Yeah, exactly.
And I think that it has been shown that women who are appropriate candidates do as well or even better with this therapy than men who receive it.
That's right.
I actually had a pacemaker and a defibrillator combo, and when I first had it implanted, it definitely gave me a lot more energy, but it didn't work for me after a while. But I did have the defibrillator part of it actually go off twice, and it did save my life. So I know it's scary to think about a pacemaker, but when the doctors explain like this really can help your quality of life, I definitely recommend people doing it.
Yeah. So I think that the point of this is there are other options, and if your symptoms are not improving, and there's lots of clinical trials, there's a lot of interest. So to not only to treat the heart failure, but really push the thriving part of this, because the pacemaker, you said, it did help you feel better for a while,
yes,
because sometimes some people's heart failure continues to progress as yours did, or not get better, but I think it's the importance of having communication with the healthcare team. One of the commenters just said the doctor-nurse-patient relationship is so important, and I think one of the things we know about heart failure, it is a team sport in terms of caring for it. So who are the members of the team that you rely upon, with the patient being in the center as the main player, the MVP?
Absolutely. I think it varies depending on your center. Most large heart failure centers or large academic heart failure centers tend to have an advanced heart failure physician leading the team. They often have heart failure advanced practice providers such as myself, heart failure nurses, ideally heart failure certified nurses. Some have medical assistants or LPNs who often assist with, documentation, rooming, things like that. But really the backbone of most heart failure clinics is the nursing. Yep. They kind of are the front lines. They are the people you speak to on a day-to-day basis, and they're the eyes and the ears of the rest of the team.
Yep. And since it is a disproportionately female profession, not completely, but it is something I think for women often feel like talking to another woman, they feel like there's a certain amount that they'll get.
Yep.
So a question I'd like to just how you handle and maybe how you received, if somebody who has heart failure is clearly not thriving, and you've done all of the things that, checking is the medication working, everything, and it does appear that this is an individual whose depression has progressed perhaps or developed. How do you broach that? Do you have somebody embedded in your practice? How do you personally handle that conversation with somebody? Because we talked earlier about stigma, but how do we get people to act?
Mm-hmm. There are a couple of screening tools that some clinics hand out right when you come into the clinic, and you fill them out on an iPad, and they are useful tools, but I find them, they're useful. They have their value. Mm-hmm. But I think the conversation is so much more valuable when you can see somebody eye to eye and you can feel their mood and you can feel what's going on. We're in my clinic, we're lucky we have a behavioral spiritual team in the building that is on call in the clinic. And their entire role is to help bridge people until they're able to establish with a psychologist team. Because all too often mental health teams are unavailable or have a long wait list, or your insurance doesn't cover it, or there's a long list of reasons why we can't get people in. So in the meantime, we have a behavioral health specialist who can literally come to clinic. I can page him and he can come to clinic, introduce himself to patients and say, hey, my name is Steve. What's going on? I understand you have a new diagnosis of heart failure. Can we talk about it? And if he's unavailable that day for whatever reason, or the patient can't wait around, we get the patient's permission and he will call them and set up a time. And he assures that nobody kind of falls through the cracks until they get in to see somebody 6 weeks later. It's a really remarkable program, and Steve is literally his name, and he's wonderful.
I had that also. Actually, I even recommend it for other hospitals to do, is after the transplant, it's such an ordeal. And when you finally are moved out of the intensive care unit, you go into like the cardiac ward. And I was about maybe 2 weeks out from my transplant. I was still in the hospital. They brought in a therapist to talk to me. And at first I was, just clearly upset. I was on a lot of steroids and your emotions are up and down, up and down. But it did help to talk to someone. And I hope other hospitals actually do that and bring more behavioral health team members in.
And so you recognize that you were having emotional roller coaster.
And you can control it.
Was there ever a time where you didn't recognize that it was depression rather than heart failure, or a combination that you had to be convinced, or did you know?
Well, I just knew, like, I would be very happy at one point, and watching Deadliest Catch, like the nurses like, don't bother Brandy when she's watching Deadliest Catch. It's a fishing show. But then I would be very sad and I would cry and I couldn't stop crying. And so, but talking to the therapist, and the nurses were amazing. I applaud all nurses everywhere. Would come in and talk to me and say that this is okay. Go ahead and cry. It's a lot of it's your medication and a lot of it is what you've been through. So
how do you have that conversation?
Yeah, I really love that. Both examples that you all have described really is normalizing this, that it's okay to say I need help, yes, or just to tell someone what's going on, and that way we can offer you the best resources to help you get through this, whether that's a therapist, whether that's a social support group, or just tinkering with your medications as well. So I'm really pleased that we're normalizing this, and that this is a conversation that we need to have in all heart failure patients.
Yeah.
Mm-hmm. And different cultures.
All patients
living
with heart failure.
And different cultures too. We have special songs in our language and in our community, and I'm sure other ethnic backgrounds have the same thing too. But be able to listen to Yeah, that
Yeah.
definitely helps.
I think that's going to be our last question for today for this, and I really appreciate the folks that have been peppering us with questions and comments and likes and a few sads and mads, because I think some of this is not about us. I don't think I have to assume it's about the topic, because a heart failure is one of those things that nobody wants to hear as a diagnosis, but that's why this panel was put together, to talk about how we will thrive with heart failure and that patients can and do, as Brandy did. So this concludes our discussion today, 7 strategies for thriving with heart failure. I'd like to thank our viewers, our panelists, and sponsors for their support of this series. I would also like to thank Women Heart and the American Association for Heart Failure Nurses for their leadership in highlighting challenges for women through diagnosis, treatment, and thriving with heart failure. Remember to consult your personal healthcare team with any questions or before modifying any care strategies. Please visit womenheart.org for more information or to learn more about connecting with women with heart disease. Thank you very much.